Thank you so much for inviting me to deliver a keynote talk at this conference. It's an exciting opportunity to participate in this conversation, and I look forward to it. I have been asked a few questions to talk about the culture-centered approach, and I will do that. Before going into these questions, I quickly want to offer you a window into what the culture-centered approach is. The culture-centered approach argues that in order to develop health communication solutions that address the needs of communities, particularly marginalized communities, we need to listen to their voices. So in order to address the inequities in health outcomes, we need to address the communicative inequalities in distribution of communicative resources, and place our emphasis on communicative justice so that we can build spaces for voices of those at the margins. Now, with that short description, I'm going to read out the questions that have been sent to me by the organizing committee and go through some of the key tenets of the culture-centered approach in relationship to these questions. So the first question is, the culture-centered approach is sometimes misused. For example, some scholars in China have applied the theory to their research but confused it with cultural sensitivity. How do you distinguish the two theories and avoid the confusion? This is an excellent question. So let me talk briefly about what is cultural sensitivity approach. Cultural sensitivity approach argues that in order to address inequities in health outcomes, you need to look at cultural characteristics of communities that experience poor outcomes and then create messages that are responsive to and that target the cultural values of those communities that experience these inequities. So cultural sensitivity in this sense is about taking cultural characteristics, finding out those that are relevant, and then creating messages that speak to these cultural characteristics. Now, that is very different from the culture-centered approach, because the culture-centered approach of the CCA argues that we need to have infrastructures for voices of communities so that community members can participate in decision making, develop grassroots-based solutions. So with respect to COVID then, so that we can have scenarios where community members can develop preventive resources or prevention programs, interventions, as well as develop community-based mutual aid, community support, and advocate for healthcare structures that are responsive to their needs. So now, the ways in which the CCA can be misused within the cultural sensitivity framework is when you take the concept of voice that the CCA talks about and use it to simply create health messages that would make the messages most effective. Now, that still is cultural sensitivity because you have already decided what the problem is. You have already decided what the solution is going to be, and then you're tailoring it in order to fit the cultural characteristic of the community. So how do you know whether you're actually doing the CCA or not? And I think I use three simple rules to figure this out. The first thing is think about who is defining the problem. In the culture-centered approach, it is the community that defines the nature of the problem to be looked at. So the problem cannot be pre-configured in that sense. Secondly, who is designing the solutions and who has the voice in shaping the solutions. In the culture-centered approach, it is the community that should be developing the solutions and have a voice, have a say in delivering the solutions. And the third point, and this is quite important, is whether the intervention is actually addressing structural inequalities or not. So the culture-centered approach argues that health communication messaging within the context of health inequities is simply inadequate to address inequities because it doesn't address the broader structural factors, the structural features, so often created within capitalist frameworks that are based upon for profit organizing of healthcare. Cultural sensitivity becomes a way for keeping capitalist power intact. So, if you were to develop culture centered interventions, you have to think about how do we dismantle, reorganize, restructure ways of organizing healthcare, uh, anchor them in socialist principles, anchor them in principles of equal distribution of resources, so that health and healthcare becomes available to all, and particularly so to the people at the margins. So clearly, to be able to do that, you have to be able to address the structural issues or structural features. Let's go to the next question. You have conducted many studies on health communication with CCA and have a wealth of experience. Yeah, I've been lucky to be working with the CCA for over 2 decades, and it's almost going to be 3 decades in a few years. And sometimes I'm amazed at what that journey has been. And you will see that, of course, in the work of the CCA, that the CCA itself has changed as I have gone through this journey. So, could you share with us some of the experiences from these studies? For instance, how to contact with the interviewees in a long term ethnographic survey? How do we encourage them to participate in the long term interviews and engage them in the practices of policy changes? What excellent questions. I really thank the organizing team and the students for reading my work so carefully. It's a humbling experience, and for engaging with it. Well, I will give you a couple of examples to elucidate this point. Let's go to one of the earliest projects with the culture centered approach. It is a project in a rural community in West Bengal. This is a part of India that I come from. In fact, West Bengal for good 30 years was governed by a democratically elected party of the left committed to socialist principles, the Communist Party of India Marxist, or CPIM. And it had very specific commitments to land reform, ensuring universal access to health and healthcare, and universal access to basic literacy. In spite of these broader structural commitments, one of the things I started observing in my work in West Bengal, and this is in the mid 1990s, around 96 when I started this work. But of course, I had a longer history in this community because I grew up within this context. And one of the things that was really striking to me is that in spite of having a pretty a decent universal um, framework of access, particularly in terms of health, in spite of having a commitment to socializing education, and in spite of significant efforts in land reform. So, we use the examples within the context of India, we use the examples of West Bengal and Kerala as two states, and both states have had a strong presence of the Communist Party. We use these as examples of two states where there have been significant land reforms. So, in spite of these significant efforts, what I observed in my work was that there were dramatic health inequalities, particularly inequalities in terms of accessing basic health resources for the community. It defined food as a fundamental resource of health, but also in terms of accessing basic health care and preventive resources. And one of the concepts of the CCA that emerged from this is that, well, even when we have a strong commitment to resource distribution, without communities having a voice, without communities have a say in decision making processes, we cannot really bring about long term transformations that address the needs of these communities. Now, how did I engage this particular community? So, as you rightly point out, this work is ethnographic, meaning that it is based upon immersion within the community. Now, within this context, I perform the role of an insider outsider researcher, as well as a community sojourner, someone who walks alongside the community in its struggles. And much of my early work, when I began the ethnography, was simply working alongside community members in their everyday struggles. So when someone would need to go to a doctor, or to access healthcare, traveling with them, when someone had difficulty accessing food, working with them, trying to figure out how food can be accessed. Now, at this point of time, I was doing my graduate work in the US, and that would mean that the time that I could spend within the community would usually be in the summer, when I could come back and spend a good bit of time within the community. Now, one of the questions with ethnographic research is how much time should you spend in a community? For me, most of the time spent was between a month to 2.5 months at a stretch, and then coming back again to spend time the following year. But in the meanwhile, what I would do is I would maintain contact. I would work with the community over the telephone in those days, because we don't really have so much social media or tools or digital tools to keep in touch. So it was really over the phone, keeping in contact every week, even when I was in the US. When community members would come up with problems, trying to brainstorm together on solutions. So that was the long-term commitment. Another example I can give you is the work we did with heart health with the African American community, or the Black community in the United States, in a town called Gary, which is in the south of Chicago. This is also the birthplace of the pop icon Michael Jackson. And Gary is also famous because it is a steel producing, it used to be a steel producing town. So it's an industrial town. But with the flight of industry from the US, that started happening really right from the early 90s onward, and it kept the industries kept moving out. A town like Gary, what happened to it is that it lost most of its jobs. So you have a predominantly African American town with low income, without access to jobs. Within this context, we partnered with a community organization called the Indiana Minority Health Coalition. It's a coalition that looked at the health outcomes of minority communities. And within this context, the health of African Americans was a particular concern, because when you compare the heart health outcomes of African Americans with those of Caucasians, there are dramatic health inequalities. So we sought to develop a culture-centered intervention emerging from within the community to address heart health. Now, one of the things with the CCA, or the culture-centered approach, is that the community has to define the problem. So within this context, it is the community that felt that heart health is an issue that needed to be addressed. And this came out from the work of the community organization, because for community members, it was very apparent that people were dying. They were dying of having a heart attack or a stroke, with very limited access to prevention and limited access to healthcare. So this work we carried out as a team. It was a large team that had community members as researchers, community advisory groups, and it was an intervention carried out and developed over a framework of 3 years. So again, it's a long-term engagement that developed over a period of time. I will wrap up with an example of the work we are doing here with communities experiencing poverty in Aotearoa, New Zealand. The ethnographic work again starts with putting together community advisory groups. These are advisory groups of community members that experience the struggles with health and healthcare, and they work together to develop a framework of the problems as well as a framework of the solutions that they think are meaningful for them. So, how do we reach out to community members when we recruit them? So, the initial ethnographic work really takes the form of volunteering, spending our own time, putting our own bodies. I talk about this a lot in my own work, that we need to place our bodies in communities when we are doing this work, in solidarity, working alongside communities when we are doing the work of the CCA. And that builds trust, that builds mutual respect, and but that also sustains the work over a period of time. Now, across all these three sites in very different countries, I talked about India, I talked about Aotearoa, New Zealand, I talked about the US. Across these contexts, one of the key things is sustainability, or sustaining the relationships. For culture centered interventions to work, it is really important that academics anchor themselves in building sustaining relationships over a period of time. So, in that sense, when an intervention wraps up, as an academic, you don't walk away from the community, but rather you commit to the community, to continuing to support the infrastructure and seeing ways in which that infrastructure can become a way for the community to access health, healthcare, and prevention. Let's go to the next question. Why are you concerned about health communication and CCA? So I read this question as asking, why did I come up with the CCA? What does it add? And perhaps why do I think it is relevant? So I see the culture-centered approach as a way for us to address the deep inequalities that we see across the globe today. If there is one thing with COVID that is quite clear to me, and of course it has been clear to many public health scholars for a while now, and it is that the kinds of health inequities that we see across the globe are unacceptable. But also, with respect to the CCA, I make the point that these health inequities are constituted by an extreme form of capitalism, the pursuit of neoliberal reforms, the pursuit of free market, the pursuit of individualism and individualist reductionism, while at the same time depleting the collective capacities of workers to organize, depleting the capacities of communities to care for each other, and really attacking spaces and sites of care. So the culture-centered approach is a way for recentering care as a principle for organizing our communities. So the center I direct, the Center for Culture-Centered Approach to Research and Evaluation, its acronym is CARE. And that is quite purposeful in the way in which we name the center as CARE, because it anchors this idea of placing care at the center of organizing our relationships. We in the CCA argue that if you want to think about human health and well-being and look at the future, we have to quickly rethink how we organize health and healthcare. That this for-profit model of organizing health is unsustainable, it is unjust, and it needs to be dismantled is a key point. And I think that communication has a big role to play in that, in terms of looking at the role of advocacy, the role of activism, and the role of policy work in reorganizing the healthcare systems. The next question: can you share your experience in contacting the interviewees and maintaining in-depth communication with them? Again, an excellent question. Now, depending upon, because the culture-centered approach is based upon the context. The method itself emerges from the context. What that means is that how you go about recruiting your interviews, how you go about building those relationships varies from context to context. Now, the culture centered approach is interested in listening to the voices of those at the margins of the margins. And what that means is that in a community where you have a lot of inequality, a community that is experiencing deprivation, say a community that is experiencing poverty, the CCA argues that even within that community, you have many layers of disenfranchisement and layers of distribution of power. So, to really understand, first of all, whom to interview in the community, one has to spend time in the community. And this is where the volunteering work comes in. This is where one needs to be in the community spaces, talking to people, trying to understand who is here, but also trying to understand who is not here. The CCA works on this concept of communicative erasure, right? We are argued that communication works to erase the voices of the disenfranchised. If that is indeed the case, then the question is how do we listen to the voices of those that have been erased? Because the ways in which we are trained methodologically in terms of our own methods is that we tend to acknowledge and see what we have been trained to or cultured into seeing. So being in the community becomes a way for starting to see what we unsee, starting to identify what are the margins of the margins, who are at the margins of the margins, so that you can start having those conversations. And oftentimes, that for us takes the work of knocking on door to door. So, to do the work of the culture centered approach, we often work in large teams of academics, collaborating with activists, collaborating with community organizers and community members that we train to be researchers with us. And we literally go from door to door, starting to get a sense of deprivation, experiences of deprivation, starting to build trust, starting to support. Someone needs a ride to the hospital, and the hospital is too far away, trying to be there for them. Someone needs food. With COVID-19 and with the lockdowns, we have had community members in various projects across the globe experience hunger because access to food has been limited. So how do we respond as a research team with addressing these food needs? And that becomes a way for building trust, but not building trust for this utilitarian purpose so that we can interview them, right? We build the trust because that is what is vital to addressing their needs of health and healthcare at that point. So I think we have to also get over this academic mind frame of interviewees and participants that we recruit to serve our utilitarian purposes and really think about what are we here to do. And if we are here to do the work of addressing the health needs of those at the margins, we really have to think about how do we ameliorate suffering, how do we address suffering in the immediate context. And I think that is what becomes an important way for us to recruit participants and to build our community networks. As I said, for some of our projects, these networks are over a decade, 10 years old. And of course, through that process now, we have many community researchers who have been trained through that, who have secured jobs, who work in the community, who run interventions in the community. But to get to that point, you have to start somewhere, and that starting point is building those relationships. The next question is, specifically with regard to China. Here I have to say that my experience working in China is fairly limited, so I want you to keep that context in mind. So what I'm going to offer is probably going to be a theoretical response to the question. China has witnessed the problem of health inequalities caused by social structural factors. This is clearly evident in a large variety of studies, particularly in terms of neoliberal reforms, how those have been constituted within the context of China. Have been really fascinated by the question of Chinese socialism and what that looks like within the context of neoliberal transformations. For example, a relatively broad economic gap exists between Eastern and Western China. Some rural areas in Western China are facing problems such as lagged healthcare systems and insufficient medical resources. But Chinese government um, tends to combine the mobilization of grassroots and top level design so as to solve the health problems of such marginalized groups. How do you think of China's healthcare system? This is such a big and complex question, and I'm going to try to respond to it with humility. So I think if you look at China's COVID-19 response, you see some really strong and excellent things. One, first of all, that it's a public health system that places public health at the foreground, that commits to a certain level of universal care and universal delivery of prevention and access to preventive resources, which I think is really important. You also see clear, consistent messaging that is aligned with then structural and policy responses, and that is another element which is vital. In our own work, with my colleague who was a postdoctoral fellow at CARE, Kang San, we have looked at the experiences of family members in left behind families in rural China. And as you point out in this question, we do witness experiences of disenfranchisement or a lack of access to health care within that context. CARE has another set of projects with workers exposed to benzene in factories and their struggles accessing the healthcare system. And in those contexts, there are inequalities and there are struggles with accessing fundamental forms of healthcare. There are also struggles with having one's voices be heard. So I think within the context of the Chinese healthcare system, you have this mix of a top-down framework and a grassroots mobilization framework, which is really good and which aligns in many ways with some of the key tenets of the CCA. The question I would put in there is that how do we ensure or how do we build infrastructures where those grassroots voices can engage with the local, regional, and national structures in ways in which they can shape policy making? How can those voices from the grassroots percolate up all the way to shaping national policies in ways in which they can address these inequalities? If you, for instance, consider the health of workers in places like Shenzhen, the health of workers in these hubs of production that have migrated to. I think this question of voice raises some really vital questions with regard to how one organizes health and healthcare. I hope that this is an opportunity to have a conversation with more of you about this and really see how within a broader commitment to a socialist organizing of healthcare can voices emerge as ways for addressing inequalities. Next question, can you provide some suggestions for the newly born major, health communication in Peking University? First of all, congratulations to the major in Peking University. You are at a vital point of time within the context of the history of the discipline and health communication. And I think your location offers you an important, a vital advantage in terms of theorizing health communication. Your ability to access the state and state infrastructures, the policy infrastructures, as well as the spaces at the margins is going to be vital to developing the theories of health communication, methodologies of health communication that address some of the most challenging issues for the next few decades and perhaps for the coming century, which is going to be about equality. How do we build spaces of health equality. Amidst these dramatic inequities and outcomes, how do we start working on them so that we actually can have healthcare grounded in political, economic, social, and cultural justice? In this conversation, I would hope that you would take your position and your context of theorizing from China, and that's the idea of cultural centering, that you would take your context seriously. So I would urge you to refrain from or to be mindful of following or copying Western models of doing health communication. I would urge you to sort of think about the decolonizing spirit of work that is happening in health communication. I would urge you to read the work on communication so wide that challenges many of the individualizing logics that have shaped the communication discipline and certainly health communication. So rather than taking another model that has been created and tested in largely white, largely European, middle class settings of the US and then imported to elsewhere in the world, think about what are the spaces of theorizing that can emerge from this context within Peking University that can hopefully offer us vital registers to think about concepts and questions of health communication. And being in China, you are at an invaluable point to participate in some of this theorizing, particularly in terms of foregrounding the question of socializing health and healthcare. I think we really need serious conversations around that. Would you like to give some advice to the postgraduates who are about to start their academic career? First of all, want to say congratulations. It's a big deal to journey through your education and to be at a point where you're ready to graduate. So congratulations. Think about the vital lessons of communication that you have learned, but also consider the ways in which you can make a difference in the world. And this is particularly so for students of health communication. If you want to study health, my hope is that you want to do that because you see the study of health communication as a way for improving lives, as a way for improving people's livelihoods and their well-being, right? So keep that in your heart and in your minds. This is something I personally have to tell myself to come back to, that why am I doing this? Why am I participating in the study of health communication? So by telling your heart that you are here because you want to improve people's lives, you want to make a difference, will offer you a solid anchor in your journey ahead. I wish you all the best. Thank you so much for participating with me in this conversation. It's been my pleasure, and hopefully this is just the beginning of many conversations with you.